everybody. It's a great pleasure for me to have Rachel Rosen as part of this incredible experience of NASCBAN visiting LASCBAN. Rachel Rosen is an attending physician from the Division of Gastroenterology, Hepatology, and Nutrition. She's the director of the Allergy Digestive Center and associate professor of pediatrics of the Harvard Medical School in Boston. Really, Rachel, we read you every day. We learn everybody of all your incredible number of published papers that we use every day with our patients, and we're really particularly happy of having you in this new experience talking about reflux and laryngitis and those things. So thank you, Rachel. It's a pleasure to have you, and I'm very grateful to be your introducer. Thanks.
Thank you so much for that kind introduction. That was completely unnecessary. And it's a pleasure to be here today to talk about a subject that is near and dear to my heart. Today, we're going to talk about laryngitis and cough, reflux versus hypersensitivity, or as I would prefer to call this talk, it's not reflux. So today we're going to talk about, is there reflux? What are the reflux parameters that we should care about? Is reflux really causing the symptoms? And what options do we have for treatment? So just to highlight the importance of reflux testing when it comes to extraesophageal symptoms, multi-channel intraluminal impedance is our go-to test to diagnose reflux in pediatrics. The advantage is it has both acid and non-acid reflux capabilities, which in pediatrics is really important. The other advantage for children with cough and laryngitis is we can tell the height of the refluxate, so we can tell if the reflux is making it up to the airway, which is particularly important. And then we're going to spend a bunch of time today talking about the correlation between reflux episodes and symptoms. The reason impedance testing is so important from our perspective is that non-acid reflux is so common in children. And I just put one study up here, but there's many that have shown this, that because children eat all of the time, what's getting refluxed is food, which is non-acidic contents. On the x-axis, you have the time from a meal, and on the y-axis, you have the percent of reflux episodes. And what you can see is that it's only when you get to 2 to 3 hours after a meal that you start to get acid into the stomach of pediatrics. And because non-acid reflux is so common, this is why reflux medicines such as antacids tend to not work. So knowing that impedance is the test that we're going to largely talk about today, we need to think about what's the best way to record the symptoms, which symptom indices should you look at, and then what is the best way to measure reflux either on or off acid suppression therapy when you care about symptom association. So our options that we typically think about are the symptom index, which is what we use here in Boston, the symptom sensitivity index, and the symptom association probability. And just to remind you of the differences between the indices, the symptom index is the number of symptoms associated with reflux over the total number of symptoms. So this is the percent of symptoms associated with reflux. The symptom sensitivity index, which is the number of reflux events associated with symptoms over the total number of reflux events. So this is the percent of reflux events associated with symptoms. And then the symptom associated probability, which is the probability that reflux and symptoms occur in the same 2-minute window. We know from pediatric studies from Tahir Omari and his group that it really depends on what symptom you care about as far as what symptom window to look at. And I just put up the cough data from Omari's paper, but they have equivalent pictures for irritability and other symptoms as well. Just to highlight that on the x-axis, you have the time interval from the time from reflux to the symptom. And on the y-axis, you have the number of coughs that are needed in order to make the test valid. And what he found was that you need at least 5 symptoms to happen during your 24-hour period. And you need to use a symptom window of 2 minutes for your impedance study. So I think this was a really helpful study for us to really get a handle on what that optimal window should be when we're doing symptom cough reflex correlations in children. We know from studies, other studies, very small studies, but studies in infants, looking at the correlation between the 3 symptom indices, that again, it depends on what symptom you care about. If you're looking at irritability versus cough, with irritability on the left and cough on the right. And what I just want to highlight is that your correlations are quite poor between the symptom index and other indices. So even though we say we're using the symptom index here in Boston, we know it doesn't correlate well with other indices. And it worries us a lot because how do we know which index is the right one to choose? Adults have shown the same thing that the pediatricians have shown, which is that there's a poor correlation between indices. In this large 772 adult study, which is quite large, they looked at a variety of symptoms, and I highlighted the cough and the ear, nose, and throat symptoms because those are the ones we're talking about today. What I want to highlight is when you look at 4 different indices, and the adults in this study used 4 different ones, the correlation between these is quite poor. And the chance that you have all 4 positive in a patient only happened in 3 patients with cough and in 1 patient with ENT symptoms. So again, it's very rare for you to have concordance between all of these symptom indices. When you just look at the SI and the SAP on the far right, it's a little bit better than all 4, but still not very good as far as the concordance between tests. So again, we talk a lot about symptom indices, but none of them correlate particularly well. How reproducible are they if you do a study from one day to the next study? The answer is not particularly reproducible. In this study in American Journal of Gastroenterology, they looked at when you use symptom indices with a 2-minute window versus a 5-minute window and looked to see how reproducible they were with 2 different impedances in the same patient on different days. And again, there was not a lot of good correlation between them. Now, I just want to highlight that in this study, their mean symptom index and symptom sensitivity index were all within the normal range. So these were not particularly ill patients. And so it's normal on day 1, it's likely to be normal on day 2, but you can see there's up to a 10-point variability between the indices. So again, you have to think about how reproducible it is when you're making a decision such as fundoplication in kids. So the next thing that we think about is we know now that they're not reproducible, but is it related to the type of reflux that the patients are having as far as how good the tests are? And this is, I think, a really important study from the Journal of Pediatrics looking at the positive symptom association in different age groups. And what they did was they broke the kids down into 1 to 6 months of age, 6 to 12 months of age, and greater than 12 months of age. And no matter which age group you look at it, about half the symptoms were reflux related. So you have a 50-50 shot of finding a symptom that's correlated with reflux. But what you need to notice is that especially in the young infants, these reflux associations are typically weakly acidic reflux. So pH less than 4, pH greater than 4. So again, if you're looking at infants, you need to think about weakly acidic reflux as the cause for driving your symptom association. As kids get older, acid becomes a much bigger player. When you looked at the same paper specifically at cough, and I think, again, that's what we're talking about today, are these extraesophageal symptoms. Looking at cough, you see that about 50% of the coughs that were associated with reflux were weakly acidic reflux. So it's not just an acid phenomenon. It's not just acid damage to the airway. Weakly acidic reflux can cause cough as well. And in an older study that we did when we looked at the cough reflux association, we found similarly, non-acid reflux was associated with cough to a much greater extent than acid reflux. And as mentioned, proximal reflux making it up to the airway, is more likely to trigger a symptom in children. Okay, so now that we recognize that non-acid reflux is an important player, should you perform your impedance testing on or off acid suppression therapy? So the first study looking at this in adults came down pretty strongly that you should perform these studies off acid suppression therapy. And I just highlighted in yellow, if patients are doing their studies off acid suppression therapy, the symptom index, the sensitivity is much higher than if you're doing it on acid suppression therapy. So our typical protocol here in Boston is to perform all studies off acid suppression therapy unless the patients are having significant symptoms on a daily basis while on PPI, and you want to see if the patient is adequately blocked or not. But typically we stop all of our acid suppression here in Boston. It does depend a little bit on what symptom you're interested in. So in this study of adults looking at heartburn, chest pain, and regurgitation, what the authors found was if you want to look at heartburn reflux correlations, you should perform your test off of acid suppression therapy because you're more likely to have a positive symptom correlation. If you're doing it for chest pain or regurgitation, it doesn't matter if you stop your acid suppression or not. Your chance of a positive symptom association is the same. Now, there's been no equivalent study of this for cough in adults, so we don't know what the data would look like as far as extraesophageal symptoms. The next thing that we have to ask is if you have a positive index, does it predict who is going to respond to acid suppression therapy or not? And the answer again depends on which symptom index you're looking at. In this adult study, they found that the symptom sensitivity index was the biggest predictor of if patients were going to respond to a 2-week trial of omeprazole. But even with that, the negative predictive value is still not great for these symptom indices. So again, we're looking at the best of an imperfect tool. Do these symptom indices predict fundoplication outcome in children? The answer is nope, it doesn't seem to be the case. In this old study that we did where we looked at impedance studies and patients that improved versus didn't improve after fundoplication, and you look specifically at the respiratory symptoms, there was no difference in the symptom index of patients with respiratory symptoms who improved after fundo compared to those that didn't improve, suggesting that these indices are not a very good predictor of clinical response. The adults showed exactly the same thing that we showed in pediatrics, where they looked at patients with a positive symptom association probability or a negative symptom association probability and how they did after fundoplication. And you can see on the left, for patients whose reflux symptoms resolved or improved, there was no significant difference in the patients who were SAP positive versus SAP negative. Again, just reinforcing the limitations of these indices. What about in the patients who you send to fundoplication and they're still symptomatic and then you do a pH impedance probe? Can you use your pH impedance probe symptom indices to predict who has reflux related to their symptoms? And the answer to that is no. I just highlighted the respiratory complications because that's what we're talking about today, that your pH impedance study really cannot predict who is going to have persistent respiratory complications. Okay, so it's sounding like things are pretty bleak for us as far as these tests go. Is there anything else that we can use these symptom indices for? And is there a reason that they're not performing so well? So what we know from studies that we've done and in the adults is that one of the reasons that these symptom indices are performing so badly is that patients are not very good at pushing the button on our recording devices when they have symptoms. We know for cough that only about 40% of all coughs are actually recorded on the patient log, which is pretty abysmal when you need to correlate cough with reflux episodes. We also know that there's a very big delay from the time when a patient has a cough and when they actually push the button. It can be as long as 30 seconds or a minute or even longer between cough and when they push the button. And I put this old picture up here, but it kind of highlights how we still haven't made much progress on improving our impedance recording. You can see in this little girl that they have 2 catheters in the nose, and they have microphones on their neck, on their little Johnny, and she has another one on her chest. And she's recording with 2 different boxes, just highlighting the different ways that we can record. The 2 catheters in the nose, one is a motility catheter to measure cough, and the microphones are measuring respiratory sound, so we can hear the cough when the kids have their reflux testing. Fluoroscopically, this is what it looks like. You have a microphone on the neck of the patient, a microphone on the chest, and then you can see there's 2 catheters sitting in this patient's esophagus with impedance sensors and manometry sensors. To show you the limitations of why these symptom indices we think are failing, this is what an impedance tracing looks like. Here you have your impedance channels, you have your pH channel, and then you have your motility channel on the bottom. Here's an acid reflux episode. Your pH goes from about 6 down to as low as 2. So there's an acid reflux episode. Your impedance picks it up. You have a drop in the blue channel, then yellow, then green. So there's a reflux episode going up all the way up into the pharynx of this patient. And then the motility catheters are detecting cough. So you can see these high pressure spikes in the chest. This is what a cough looks like. So this patient had 3 separate coughs. They pushed the button only once, and you can see there's a very long time delay from when the reflux episode happened to when they actually pushed the button. So we think this is why our symptom correlations are so flawed. We know that by putting a manometry catheter in patients, you can improve your cough symptom association by more than 1/3, which is a significant improvement over where we started. Using impedance technology, we now know that reflux episodes are not associated with bronchiectasis, airway surgery, oxygen weaning, apnea, fussiness, arching, and colic. So even though reflux is typically blamed for a variety of these extraesophageal symptoms, impedance studies have shown that there's no correlation between these respiratory diseases and reflux parameters. And even worse, what we've shown is that it not only doesn't correlate with any of those diseases, but it doesn't correlate with more severe disease. We looked at using at all of the impedance studies that were done at Boston Children's and looked to find out if patients who had abnormal impedance studies were admitted to the hospital more frequently than patients that had normal reflux testing. And what we found was that there was no association between how much reflux you have and how frequently you were admitted to the hospital, even in patients who aspirate. So again, the test measuring the amount of reflux doesn't really predict extraesophageal reflux morbidity. The other thing that we found using impedance technology is that we can't correlate the amount of reflux we have with the appearance of the airway. So here we have an epidemic of people getting diagnosed with a red airway. So to solve this problem, we videotaped the airway exams of children undergoing a laryngoscopy and bronchoscopy. We blinded the videos and had 3 different ENTs score the airway. In those same patients, they all had reflux testing, and we measured the amount of reflux that they had. On the left, you can see the correlation between the amount of reflux on the x-axis and the reflux finding score, which is the airway score that the ENTs scored for the amount of redness. And what you can see is that there's no correlation at all between their score and the amount of reflux that kids had. And then I specifically pulled out the erythema score because redness is the most common reason that we see referrals. And there's no relationship between the amount of reflux a patient has, including the amount of full column reflux, and how red the airways are. So now we've used impedance to debunk this idea that red airways are a sign of anything related to the esophagus. We also know that these symptoms like cough, wheezing, gagging, choking, apneas, and desaturations are frequently blamed on reflux, but we need to think beyond the reflux diagnosis. And in particular, we need to think about aspiration. And I just highlighted the cough and the apnea and desaturation odds ratios. But again, you're more likely to have aspiration during swallowing with these symptoms than you are to have gastroesophageal reflux. So you really need to think about getting a swallow study more than you need to think about getting an impedance study. And just to highlight the babies, you know, we have an epidemic of these babies getting admitted to the hospital with color changes and choking episodes. The most commonly positive test in babies with choking or color spells are actually an abnormal video fluoroscopic study, not an impedance study. And so really you need to think about the swallowing issues much more than reflux. And even though we have consistently proved this in our hospital, and we've spoken to all of our hospitalists about this, still they're sending about 1/3 of patients home on proton pump inhibitors, even though we told them that this isn't a reflux problem. So again, there's just lots of education to do. And then just to highlight that not only are we particularly bad about blaming reflux, but we're also not very good about watching these babies and making the correct diagnosis. There's many studies that have shown that you can't look at a baby to predict who's having reflux. And similarly, you can't look at a feeding baby and predict who's aspirating, that an observed feeding only diagnoses aspiration in about 40% of the cases. So again, you have to think about diagnostic testing. Now, apart from swallowing issues, the other thing that you need to think about as a masquerader of gastroesophageal reflux is gastric dysmotility. And I think this is particularly important in the kids who have really high risk for lung disease. And we think a lot about the lung transplant populations. And I just put this up here because I know we're talking about cough and airway disease, but there's no population that's more at risk than the transplant patients. When we looked at lung transplant outcomes, the biggest predictor that we found of a poor lung transplant outcome was gastric dysmotility. Patients who had gastric dysmotility were 33 times more likely to reject their lungs than patients without dysmotility. This is a really big problem. Now, if you're a disbeliever, you could say, well, of course, they have dysmotility, their stomach's not emptying, those patients are going to have more reflux, and that's why they're doing so badly from a lung perspective. But when we looked at their impedance testing on the left, or their response to fundoplication, what we found was that their poor lung outcomes had nothing to do with the amount of reflux they had, and had nothing to do with whether they had anti-reflux surgery. These patients were having worse outcomes simply because of their dysmotility, independently of their reflux. And I think this is really an important point, because these kids with gastric dysmotility look for all the world like they're having reflux, but when you do their probes, they're not. So why are they having worse lung outcomes? So one of the things we've learned now is that there's lots of overlapping microbiome between the lung and the GI tract. Now, we used to say, oh, well, the reason that there's overlap is acid, and the acid lands in the lungs and causes a pneumonitis. But in fact, what we find is that actually it's bacterial exchange between the two sites that tends to cause the respiratory symptoms, we think, in these patients. And I just highlighted in the middle the key piece of this slide, which is we looked at the frequency with which there's bacterial overlap between the lung and the gastric fluid. And any number on the y-axis that's closer to 0 shows more complete overlap. There's just as much overlap between the bacteria of the lungs and the stomach as there is between the mouth and the stomach. So that really just highlights for us how when you mess with the microbiome in one area, you're going to have upstream effects. And I think that will become important as I show you some more data. In particular, we looked at patients with abnormal gastric emptying scans, and we looked at the diversity of the microbiome on the left in their lungs and on the middle on their gastric fluid. And what I just want to highlight is that when you have abnormal motility, you have much less diversity of the microbiome in your lungs and the GI tract. And that's particularly the case in the lung transplant patients, which are the clear boxes, the non-striped boxes. So again, it seems that there's lots of overlap between the GI tract and the lungs. And it seems to be that when you have dysmotility, you have a much less diverse microbiome, which could impact respiratory symptoms. All right, so what are the options for therapy? While we're talking about microbiome disturbances, let's go straight to the proton pump inhibitors. Proton pump inhibitors have been used for a long time to treat extraesophageal symptoms. And I just want to highlight this most recent, very large trial that came out in adults looking at lansoprazole versus placebo for pharyngeal symptoms such as laringitis. And in the study, they found no benefit of lansoprazole over placebo for pharyngeal symptoms. Again, just reinforcing the point that either this isn't reflux or it's not acidic reflux. We also know that proton pump inhibitors don't change the appearance of the airway. In this meta-analysis that was done in 2016, they looked at studies of placebo versus proton pump inhibitor and patients who had airway exams to see if the redness of the airway improved after PPI compared to placebo. And what they found was that there was no benefit of proton pump inhibitors to improving the appearance of the airway. What about other uses for proton pump inhibitors for laryngeal symptoms? This is a study that we just submitted looking at the frequency with which patients or infants who were started on proton pump inhibitors go to supraglottoplasty for laryngomalacia. So how frequently babies with noisy breathing go on to surgery if they're started on a PPI. What we found on the left is that actually, if you're started on a PPI, you have a worse outcome. You're more likely to go to surgery than if you weren't started on your proton pump inhibitor. Now, there's people that are going to say, well, of course, that's the case. The sicker patients go on proton pump inhibitors, so they're more likely to go to surgery anyway. But when we looked specifically at the moderate to severe subpopulation, patients started on PPI still didn't avoid surgery at any greater rate. So even in severe disease, PPIs did not prevent the need for surgery. We also know from the randomized control trials in infants, lansoprazole did not improve extraesophageal symptoms. And again, I put in the box the coughing, wheezing, hoarseness, pharyngeal, and airway symptoms, showing no benefit of lansoprazole in infants. And again, if you need even more data, the trial in adults in APT looking at PPIs for the treatment of cough using a quality of life cough score, showing no benefit of PPI over placebo. The only area where there has been shown to be some potential benefit is postnasal drip in adults. For patients who have postnasal drip, there may be symptom improvement after 4 months with PPI use to treat postnasal drip. Now, as I mentioned with the gastroparesis data, we worry a lot about microbiome changes related to PPIs. PPIs, if we worry a lot that if we change the gastric microbiome, we're going to have upstream effects on the lung. We know that PPI use is associated with upper respiratory infections and pharyngitis and pneumonia. So again, the extraesophageal symptoms that you're treating may be made worse by the proton pump inhibitors by changing the infection risk. We know that your infection risk on using proton pump inhibitors depends on how you metabolize the proton pump inhibitor. So for example, if your CYP2C19 status is unfavorable, you may be more likely to get infection. So if in the picture below, what you see on the bottom is PM, which are poor metabolizers. These are the patients who can't metabolize the drug, so they have more circulating drug in their system. If you have more circulating drug, that means you're more heavily acid suppressed, which means you're more likely to have microbiome disturbances. And in this population of poor metabolizers, patients were more likely to get upper respiratory tract infections and sore throats if you're started on a PPI. So if you're going to use PPIs for extraesophageal symptoms, you may want to consider getting their PPI genetics screened. Well, what other factors are associated with infections and when you start a PPI? I already told you about the CYP2C19 status, which is highlighted in the top, that how you metabolize is more likely associated with infections. But I also just want to highlight that having a gastric dysmotility disorder is also associated with increased infection risk. So again, just getting back to that theme that you need to know if there's dysmotility and treat the dysmotility, because that also affects your risk of things like laryngitis, pneumonia, sore throats, and upper respiratory tract infections. We talked a lot about bacterial infections and the risk for pneumonia and pharyngitis. We also know that PPIs are now associated with viral infections. And I just put up the 2 COVID studies that have come out in adults, which were very concerning to us, showing on the top, the PPI use is more likely to be associated with testing positive for COVID. And on the bottom, you're more likely to have more severe COVID symptoms. So PPI use was associated with increased oxygen requirement, ICU admission, needing for mechanical ventilation, and death. So again, it seems that PPIs change your viral risk as well. As if that wasn't enough, not only do the PPIs have not been ever shown to benefit extraesophageal symptoms, not only did they change the microbiome, but they may also change your risk for allergic disease. And again, if you're treating chronic cough, the last thing you want to do is trigger asthma in a patient that causes chronic cough. In this study from JAMA Pediatrics in 2018, the authors found that acid suppression use was most likely associated with food allergies, asthma development, atopic dermatitis, you name it, it's been associated with allergic disease. And in particular, it's also been associated with eosinophilic esophagitis. So when you look at risk of developing eosinophilic esophagitis, early proton pump inhibitor use was associated with almost a 3 times greater risk of developing EOE. Now, again, the reason this is important is because in children under the age of 5, the primary presenting symptom for EOE is cough. So if you're trying to treat cough with proton pump inhibitors, and then you give the patient eosinophilic esophagitis, they may be dealing with chronic cough for a much longer period of time. And then fracture risk, I just mentioned this because when patients have chronic cough, frequently they're on different asthma therapies, inhaled steroids or steroid bursts. And what we know is the PPI use has been associated with increased risk of fracture. And if you put the patients also on steroids, you may make their fracture risk even worse. All right, so what other therapeutic options do we have? I put this out here because, again, this is not an extraesophageal symptom trial, but I think it raises some really interesting topics. So in this study, this was an adult study of intractable heartburn. What the authors did in this study was treated adults with either placebo or a bile acid sequestrant to bind bile, with a thought that if you bind bile, you decrease esophageal inflammation and heartburn. The authors found that bile acid sequestrants did in fact improve heartburn symptoms. Okay, so what is the relevance of this to the lungs? In this paper that we just submitted, we looked in 70 kids at their gastric fluid and in their lung fluid, and we measured the amount of bile that was present in both sites. What we found was that 100% of pediatric stomachs had bile in the stomach, and we found that 98% of the lung samples that we sampled had bile in the lungs, which is really concerning to us because bile, at least in the lung transplant population, has been associated with worse outcomes. We then took the patients and we stratified them into high and low lung bile concentrations. And what we found was that the patients who were in the upper quartile of bile in the lungs had much worse pulmonary outcomes, with more hospitalizations and more hospital days than patients with low lung bile. So this raises the possibility that bile acid sequestrants may be of value in treating extraesophageal disease in pediatrics. Okay, so what else besides bile? Well, we're talking a bit about airway sensitivity. We talked about how acid doesn't seem to be a big player in pediatrics and how antacids don't help. What other options do we have? And I put this up here because this is absolutely not a GI paper. This has nothing to do with gastroesophageal reflux. This was purely a trial of a tricyclic antidepressant versus gabapentin to treat chronic cough. And what they found in the study was whether you use gabapentin or tricyclics, both as neuromodulators, chronic cough improved over time. So again, cough can be like the irritable bowel syndrome of the airway, where you use your IBS drugs to treat chronic cough. You also changed the airway sensitivity. So in this more recent trial, this was a study of gabapentin, which is a neuromodulator, versus baclofen, which is used as an anti-reflux drug. And what they did was adults were given either gabapentin or baclofen, and then they checked their airway sensitivity by exposing their airway to capsaicin. And on the left, you have the data with your gabapentin, and on the right, you have the baclofen. And what you see is that whether you pick a reflux therapy or you pick a neuromodulator, airway sensitivity improved. So again, it doesn't really matter which therapy you'll pick. And when you compared them head-to-head, gabapentin versus baclofen for cough symptom improvement, you see that they improve exactly the same no matter which therapy you pick, whether you pick a reflux therapy or a neuromodulator. So again, this opens the door for non-PPI related therapies. Now, the other thing to just bring up is not only just the sensory part of chronic cough in patients, but also there may be a motility component. And again, we talked about the gastric dysmotility, but we do need to talk about the esophageal dysmotility. I put this up here because I think this highlights the complexities of just measuring the percent time pH less than 4 in the esophagus. So just to orient you, on the left-hand side, you have the total acid exposure time, so the percent time pH less than 4. On the right side of the screen, you have the nocturnal baseline impedance. So low baseline impedance is a sign of dysmotility or esophagitis. On the x-axis, you have the percent of swallows that are abnormal. So here, 100% of swallows are abnormal versus normal number of swallows that are normal swallows. I want to highlight in blue, this is the acid exposure time. As your number of swallows gets more and more abnormal, your reflux gets worse and worse. And again, why is that? It's not because you're having more reflux. It's because any reflux you have, you can't clear. And that correlates with a drop in impedance of the esophagus. So again, this is really important that unless you improve the dysmotility of the esophagus, you're not going to improve your pH portion of your pH impedance study. And there's other studies that have supported this link between esophageal dysmotility and respiratory symptoms. In this study, they looked at the proportion of patients with long breaks in the esophagus. So these are patients who had esophageal motility studies that had a disruption of their esophageal peristalsis in the middle of the esophagus. As the proportion of patients with long breaks increases, the number of patients with cough increases. So poor peristalsis is associated with worse cough. And again, when you look at response to proton pump inhibitors, which is on the right, having long breaks in your esophagus predicted a poor response to standard acid suppression therapy. Again, because you have to correct the dysmotility. You can't just treat with PPIs. So how do we correct the dysmotility? We typically use prucalopride, which is akin to cisapride, but without the cardiac effects. And again, I'm just showing you this adult study. On the bottom, focus on the percent of patients with complete peristalsis. You significantly increase the complete peristalsis when you prescribe prucalopride to patients compared to placebo. We know that this translates into improved pH parameters. On the left, you have the percent time pH less than 4, patients who receive the placebo versus prucalopride, and you see significant improvements in the pH parameters. And on the right, you have the gastric emptying. Patients who got prucalopride had much faster gastric emptying compared to placebo. So again, for patients with persistent abnormal pH less than 4 who have dysmotility, prucalopride is something to think about. We know in pediatrics that there seems to be a benefit, and this is a paper that we've since submitted, looking at the improvement of patients on prucalopride, and we looked at a variety of upper tract symptoms, feeding difficulties, nausea, reflux, vomiting, and found that about 67% of patients given prucalopride had an improvement in their upper symptoms in pediatrics. All right, well, what about fundoplication to treat extraesophageal symptoms? I already told you that the reflux parameters don't seem to correlate. The PPIs don't seem to improve outcomes, but not to be deterred, many people are still doing fundoplications for extraesophageal symptoms. In this study, looking at esomeprazole versus fundoplication for respiratory symptoms, this study looked at not only symptoms, but objective measures of lung dysfunction. And on the top, you have exhaled nitric oxide as a marker of lung inflammation. And on the bottom, you have FEV1 as a marker of lung function. The number 1 Roman numeral is at baseline. Patients were then given esomeprazole, which gets you to the second measurement. And then the patients underwent fundoplication, which gets you to the third measurement. And no matter what stage you look at, either the baseline to PPI or from the PPI to fundoplication, there was no improvement in any objective measures of lung function. What about for laryngeal symptoms? This is an old study and it's a small study, but it's the only one of its kind. Patients with suspected LPR then got a PPI trial for 4 months. Then the non-responders then went on to either fundoplication or continued PPI. And regardless of whether you got PPI or surgery, those patients tended to not respond to therapy, with the same number of patients responding in both the surgery and PPI group, with the vast majority of patients, 90%, still having persistent symptoms. The next thought would be, well, maybe they're having persistent symptoms because the fundoplication might have been too loose or the PPI dose wasn't high enough, and that probably they still had airway inflammation. But in the study, they actually looked at the amount of airway inflammation within 12 months after fundoplication, and I've circled that. And you can see that despite 90% of patients still having symptoms, all of them had complete resolution of the appearance of the airway. So that just highlights that you can have airway improvement, the visual appearance improves, but you're still very symptomatic, suggesting that the airway inflammation that ENT is seeing is really not very meaningful when it comes to patients' symptoms or quality of life. And then I just want to highlight why we tend to be so negative on fundoplication, particularly in patients with respiratory symptoms. This is a high resolution esophageal motility study of a fundoplication patient. Just to orient you, this is the upper esophageal sphincter here. This is a high pressure band. When the patient swallows, it goes from yellow to blue, where you can see my cursor. That's the upper esophageal sphincter relaxing. You can see moving down the esophagus, these yellow waves, which is the peristalsis coming down the esophagus. And when you look at this, the peristalsis looks pretty great. Here's your lower esophageal sphincter, which is this high pressure band down low where my cursor is. And when the patient swallows, it goes from yellow to a lighter blue. And again, lighter blue here when the patient swallows. This is what a fundoplication looks like. And for all purposes, it looks like the fundoplication is not too tight because the lower esophageal sphincter is relaxing. When you put impedance on top of this, this is what it looks like. So wherever you see pink is where you have fluid. When a swallow comes down, you can see that the pink is cleared and then enters the stomach, and the whole stomach on the bottom is pink. What you can see is that even though this patient had what appeared to be normal peristalsis, I put in circles 3 areas of pink in the esophagus. You have pooling right under the upper esophageal sphincter. You have pooling in the mid-esophagus for this patient. And then you have pooling right above the fundoplication. So again, even though this looks like an intact fundoplication with normal peristalsis and normal relaxation of the fundoplication, you can see that fluid is still sitting in this patient's chest. And so when this patient lays down, they're going to get the same cough and wheezing and extraesophageal symptoms that look like gastroesophageal reflux, except the fluid is not coming from the stomach. It's coming from the chest because it's pooling over the fundoplication. So this is exactly why we worry about doing fundoplications in children with respiratory symptoms. It's because in our experience, you often create a bigger problem by having things sitting in the chest for longer periods of time. So just to summarize and end, reflex testing is only one data point. I tried to show you that symptom indices are really flawed, that doing pH impedance testing doesn't typically correlate with any outcomes, and treatment for reflux doesn't seem to improve outcomes. PPIs have never been shown to improve extraesophageal symptoms, and we strongly recommend against using them. Fundoplication has also not been shown to improve extraesophageal symptoms, especially in babies. Symptoms that we used to think were reflux, we now know are aspiration during swallowing. And so we strongly recommend not using fundoplication for extraesophageal symptoms. And then lastly, dysmotility, both of the esophagus and the stomach may be bigger problems than acid reflux alone. And you really need to think about getting testing for motility whenever possible if patients aren't responding to your standard therapies. So thank you so much for your time, and I will pause for questions. Thank you.